Welcome to the ResearchWorks podcast, broadcasting live from the Oceania Academy of Cerebral Palsy and Other Childhood Onset Disabilities Conference 2026 in the beautiful city of Hobart, Australia. Join Dr. Dana Poole and the ResearchWorks team as we bring you an exclusive series of interviews with visionary keynote speakers and leading presenters, captured right here amid the groundbreaking discussions and innovations shaping the future of disability research and care.
Hello everyone, welcome back. Another episode here of ResearchWorks at Oceania Conference 2026 in Tasmania. It's been wonderful to be here. The conference is about to come to a close, but that doesn't mean we don't have excellent content for you. In fact, the two people who I have sitting in front of me are friends, and I tend to only seem to see them outside of Perth. They both live in Perth from time to time, and somehow we still manage to connect on other sides of the country or other sides of the world. So enough of the preamble. Welcome to the podcast, Alison Salt. Hello.
Hello.
Good to have you back. You were in the first few seasons of the podcast, and it's lovely to have you back to talk about an area that you're very passionate about. And I also have another friend of the show. Actually, we met a few years ago somewhere in Europe. I can't remember the first. It was actually in Belgium,
Yes.
wasn't it? And now you live in Perth. And of course, I don't see you in Perth, but I see you in Hobart.
Yes.
So Nofar Ben Itzhak.
Yes.
Did I do it right?
Yes, you did.
I did. Did you hear it? Yes.
Amazing.
Thank you.
Yes, hello.
Hello, welcome. You both presented at a workshop this conference, and we haven't had a lot of content when it comes to this particular area for a little while. And so this is such a great opportunity to get a little bit of upskilling, a bit of knowledge and education. It's part of an evolving bigger piece of work that is still coming, but we can still probably talk a lot about the actual issue at hand, which is around cerebral visual impairment. So the title of your workshop was Advancing Early Detection and Assessment in Cerebral Visual Impairment, or CVI, with Australian and Belgium habilitation practice examples. That's a nice sounding workshop. Sounds like it was action-packed. A lot to put in there.
Yes.
So, look, it's wonderful to be able to talk to people who know a lot about this area, because I think it's something that people know about and you might acknowledge that it's there. But in terms of truly understanding what it means for the children that we work with, I don't think that's as widespread as we'd like it to be, which is probably part of the work you're trying to do. So let's start from the very beginning. What in the first place is CVI? Because it's no longer cortical visual impairment. It's what it used to be called, wasn't it? And that's really made a change. So Alison, do you want to tackle this one?
Sure. Cerebral visual impairment. It's interesting, Dana, because when we, as part of the development of clinical practice guidelines for CVI, which are on their way, the publication is almost finished and is very soon to be published.
Wonderful.
So look out.
Yes.
DMCN should be coming out.
Wonderful.
We hope, as long as the review process isn't too long. But when we were doing the systematic review, we found that really we don't even have an operational definition for CVI.
Oh.
So we have, so far we have people use a definition of exclusion. So cerebral visual impairment is a condition that is not a visual disorder, that is not due to problems with the eye or the anterior visual pathway.
Okay.
But not actually an operational, what is it?
I see.
So that was sort of the first thing in the guidelines that we had to really tackle. So it's going to be really important for us to get this out there so that people really start to use the same definitions, the same standardized assessment practice.
Sure.
That was the whole idea about the guidelines. So I guess our talk today was really using what we know about the guidelines so far to frame some of the sort of ideas that we talked about in our conference. But CVI is a really complex disorder. It covers really visual impairment, which are disorders of visual function of lower order and higher order visual function, really that are due to problems arising in the brain. And often the early development of the brain.
Yes.
So essentially it is a neurodevelopmental disorder, and that's quite a new concept to think about.
Absolutely is.
And the other important aspect is that it affects many of the children that we see. So we're working with many of our colleagues here in this conference are working with children with cerebral palsy, and up to nearly 70% of children with that condition will have some level of CVI.
Wow, that's actually a very high number.
It's a very high number.
Isn't it? It's more than half of the children that we might see. Do we know much about the spread across the GMFCS levels? Like, do you tend to see it more in some GMFCS compared to others, or is that really quite difficult to say?
Well, I think that's really interesting, because in this part of the talk, I talked about children that might present early with infancy with very severe visual problems, and they're likely to be the children that have experienced the most severe levels of brain injury, potentially.
Yes, okay.
But there are also children who appear to have pretty normal visual acuity and don't present until much later in school age. And they could well be those children with GMFCS level 1 or 2.
Wow.
So and even sometimes children who don't have cerebral palsy but have no risk factors at all.
Wow.
So Nofar talked a lot about those children with who have better vision and higher level visual difficulties. And I tackled a lot around sort of infancy and infancy presentation.
Yeah, brilliant. It's so interesting to know that, isn't it? Because I think there are a lot of assumptions that are often made about what we think we know about CVI. And it feels like that's one of them already. You know, you would, I mean, actually found out from a family that we have worked with for a very long time, and she's now in high school, and she's probably classified around GMSS level 2, and they've just confirmed that she has CVI, and she's very intelligent, has done really well in school, but has had some struggles, and it's been really difficult for her in school. And it was quite a shock to see that would be the case. And it just shows that the operational definition will be really important to get everyone on the same page, and why it's so important to have this article that's soon to be published for people to follow along. So a little bit more about how it presents. Maybe let's start from an infancy perspective for the really young children. How might we suspect someone has CVI? Can you see it on an MRI? How do you actually identify? Because vision always seems to be something that someone needs to report to you what they can see. So what does that look like?
Sure. Well, I mean, first of all, we know that there are children who are at higher risk. So really you just think about all the risk factors for cerebral palsy. Yeah. And you have all the risk factors for cerebral visual impairment.
Okay.
So, of course, you've got to be alert to the problems with vision in any of those children. We have to be already thinking about that as a possibility from the first time we meet the infant and baby. Really, they can present from really showing no visual response at all.
Right.
What we presented in the conference was about early screening for visual impairment in our service in Western Australia, because we were feeling that, while we were looking out for visual difficulties, we didn't have a systematic approach to it.
Sure.
And so we now have a service in Western Australia for all children at risk of cerebral palsy come immediately through from the neonatal services to our service, and we're often now seeing them from even 4 weeks, 6 weeks of age, so very, very young.
Okay.
And they're often referred directly from the neonatal service even before they've left, and usually because they've had risk factors such as intraventricular hemorrhage or some brain impact, stroke, etc.
Okay.
That means that they are at risk of cerebral palsy. So we wanted to look at those children and just make sure that we were picking up on visual difficulties. So we designed a really simple tool, which is essentially a form that all of our allied health professionals who met the families for the first time could complete.
Okay.
So we did a very brief training for our allied health team, whether they be physios, OTs, or speech therapists. And with this sheet, they could essentially follow some very simple guidelines about what we might expect of an infant at that age, what they should be doing with their vision. So do they look at mother's face? Is the parent concerned? Probably the most important. And that was one of the most important risk factors that we picked up on the screening tool. Do they fix and follow a black and white target, a very simple target? Do they fix and follow a small yellow ball at 30 centimetres? 30 centimetres away, just dangling in front of them. And also, were there anything different about the way the baby's eyes were moving, whether they had a squint? So just some very simple questions.
Yes.
And we followed up all of those babies over the first year of this project and found that the tool picked up with 100% sensitivity all of the babies that had problems. We didn't miss any. So high sensitivity on a very simple tool. And I think the message to the audience today was that, really anyone can do this. It's a systematic observation of what a baby is supposed to be doing with their vision. And I think we often, or professionals often, feel a little bit lacking in confidence about vision. They don't feel they've been trained in it. They maybe feel that it needs an expert but I think the message really is that anyone, if you ask the right questions and take a systematic approach to your observations, you can tell a lot about the child's vision. And of course, we also want them to go directly to the ophthalmologist because we do want to make sure that the child presenting with visual problems does not have some treatable eye condition.
Of course.
We want to make sure they don't need glasses, they don't have a squint that needs treatment, or even more so, they don't have cataracts or glaucoma or some very significant eye problem that can be treated. So clearly the ophthalmology pathway is really important too. But then if you pick up problems, taking them on to more detailed assessment is really, really important.
That's fantastic. So, this screen that can happen very early on can send people down the right path of making sure that they're going to see the right people. But also, I suppose you can start to implement some strategies quite early on to be very intentional about what you might be doing in interventions. Is that what that's also designed for?
Absolutely, because vision is absolutely critical to everything a baby learns. It's the pathway to learning, really. So we need to immediately intervene and support that baby's vision to develop as rapidly as possible, but also to make sure that their learning environment is adapted so that what little vision they might have can be used to support their learning goals.
So as part of the interventions or treatments that are provided during this time, are they about trying to harness as much of what the child already has? Is there the possibility of gaining greater vision through experience and exposure? Like, what are the possibilities? And I suppose on that, that's a screen, when does CVI actually get diagnosed? From what age? When can that happen?
I think we can diagnose it from any age. There are neonatal, we can look at vision even in the neonatal period.
Right.
There are tools like Daniela Ricci's developed a neonatal assessment tool, very similar to our screen, but more focused on black and white images, moving slowly. So you can pick up on severe visual impairment early. But I think the other thing that, yes, you said, could vision develop? And definitely the answer is yes, because vision is, the brain is developing. We know about neuroplasticity. The brain is developing. It might start with a very limited vision, but essentially the baby has to learn they have to learn what it is they're seeing.
Of course.
They don't just look out in the world and know. So if a baby has very poor vision, you can actually help that vision to develop more rapidly.
The interpretation of what they see.
The interpretation, it's how the brain is processing that information. So you can help make it more salient and more relevant and help the baby know what they're looking at, even if it's very degraded.
Yeah, okay. I find that very hopeful, isn't it? It's something that there's
very
action
hopeful.
that you can do, which I feel like in our area, sometimes we don't have those things.
I think the other thing is really important is that vision, it can change. And sometimes these babies even appear then to have quite normal vision after a time, which is great. It's fantastic. But that's probably why it's really important to just keep monitoring, though, because sometimes maybe the acuity, the ability to see detail has improved.
Right. Yes.
But it's possible that that child's visual processing at a higher order level may not be as good. And we did illustrate with a case, delightful girl with GMF who has cerebral palsy, who has GMFCS level 5 cerebral palsy, but very able, lovely girl who presented as a baby with quite poor vision, which improved. And then we met her again when she was 11. And at that stage, people were beginning to wonder, is there a problem? Is there something else going on? And we, after further assessment, realized that indeed she did have cerebral visual impairment. And for that child, even though she had perfect acuity, she could read the smallest letters.
Wow.
She had very significant problems with processing visual information to the point where she could walk into a room and say, I can't see anything until I really look around very deliberately, carefully, and work out what things are, and had trouble seeing letters that are very closely spaced because they were too cluttered.
Wow.
So really, I think that's probably where we might give Nofar a chance to talk about children who have problems with higher visual order processing.
Well, that was a brilliant summary right there and then. And like I said, it's just wonderful to know that you can implement a screening process, that you're able to roll out across the hospital and give the confidence in the people who are often seeing these children very early on, but to be able to provide strategies very, very early on as well to support that child in their development. It's such a crucial point in time. But yes, as they get older, what does that look like, Nofar? And what are some of the key presentation points that you might see? I know Alison touched on a little bit there as well from that case study.
Yeah. So for us, we termed it in the presentation a sort of hidden struggle.
Yeah.
So these are children who go to school, and to the outside world and their teachers, they may appear like they're struggling in school, but they're also misbehaving in a way. And so the issue here is not that they necessarily have a visual acuity problem or any ocular problems. It's more that they're unable to process the complex world around them, and it's just sort of overstimulating and can create visual fatigue, for example. And so when the child gets the correct supports and you adapt the environment, for example, to make it less cluttered, to teach them ways to compensate, this provides them a safe space, and then they actually become a successful student because their vision has been supported and promoted also in school. So it's not that they have behavioral difficulty, it's that they have CVI, for example.
Oh, that's really interesting. I've got so many questions. So to tease that out take a very inquisitive mind to tease that out, I can see, because I can imagine with behavioral difficulties within classrooms, how much does this coexist with, say, ADHD, which often, can sort of unmask when they start having more challenges at school. They're 7 or 8 years old. How do they coexist? Is there a differential diagnosis? How do you tease that out?
So in my opinion, it is important to have differential diagnosis, and that's why the diagnostic team needs to be a multidisciplinary team. So including medical professionals, also allied health specialists, but also to include there the parents who observe the child, and they have very important information to share.
Yeah.
And we have questionnaires which we can use to help understand the visual experience and the functional vision of the child in daily life.
Yes.
And also to include the teachers and the perceptions of the teachers. So there is an important part here about the multidisciplinary assessment, the differential diagnosis, and also these diagnoses can coexist.
Of course.
So autism, ADHD, there are numerous that can coexist. So there's a lot of work there.
I bet there is. But in terms of what I haven't heard of as much, it hasn't been as mainstream, I suppose, is when people are going for these assessments, potentially for ADHD and ASD, are vision assessments incorporated as part of that to differentiate that out? Or is that the whole reason why you want to do the guidelines? Is it part of that?
Part of assessment of ADHD and ASD, possibly not, if the child hasn't been presenting with any specific visual difficulties, but almost the reverse is true, that sometimes, a symptom, if someone might say, someone might be saying, I think my child might have visual difficulties, but in fact, when you work through the differential diagnosis, the difficulties might be general attention. It's not so much visual. So differentiating the two is really important, and not ascribing one to the other. But then sometimes they do coexist.
Yeah.
So it does need quite a careful thinking through.
For sure.
And Nofar mentioned the questionnaires, and they really can be very useful to structure parents' and professionals' observations, but they aren't specific. So there might be, issues that are raised that could have a number of different explanations.
That you then need to go down to
so
investigate
you need to,
more.
Yes. Could it be actually the physical or a coordination problem?
Of course.
Or is it visually driven? Or is it attention?
Yes.
Or could it be a social impairment, in fact, why a child is not making eye contact? So, trying to unpick all of that is really very important. And as Nofar said, why we need that multidisciplinary team to understand it.
Yeah.
Yeah, and maybe I have actually like a real scenario, because when we use the questionnaires, then we do have, for example, the object recognition as one of the domains we measure. But indeed, as Alison said, we found a relation between autism. So it explained some of the variation and the differences. So if a child had autism and CVI, they were more likely to have a object recognition difficulty, which included also the face perception and so on. And also we found relations with developmental coordination disorder and some of the moving in space and cerebral palsy and moving in space. So then you question, are those the elements? It's very hard to distinguish, and I don't think there's much research done into really trying to flesh it out.
And I think I often say that in a way it is us professionals who put these boundaries around these particular diagnoses.
Right.
We have to find a description or a label that helps us to understand the child best. But actually the human brain is not really like that. It's much more complex.
That's right, yes.
And so every child is really an individual, and understanding their symptoms, their presentation, their difficulties and weaknesses is possibly more important than labeling. Although we do, obviously labeling has its uses. It has it helps people to think about what kind of support the child might need. But I think it is really important that we do identify what the areas of weakness and that need support are.
Sure.
Because if we ascribe everything, say, to CVI and miss the fact that the child has significant social communication challenges that might need support, then you're not really helping the child. So really we have to use and understand the child well and use the most appropriate descriptions that provide the most help.
Yeah, and it's genuinely a holistic approach, isn't it? And you're right, like sometimes names, diagnostic groups, you can really compartmentalize the kind of support that they might need. Often it's how the systems work, right? And you follow down a certain path, which is, I suppose, why it's so important, the work that you're doing, is to recognize this area exists and not to fall between the gaps as we're moving through really important stages of a child's life.
Yeah. So we like to talk about profiles, really understanding the child's profile and that each child is unique.
Yeah.
And not to, try to lump everything into like a basket of CVI that has, these are the symptoms that a child with CVI has. That I don't think is a very useful approach.
Sure.
I think it's much more important to think of that individual child and their individual profile, which can be very different, can't they?
Yeah. Can you talk us through a little bit more about that now, Nofar, about the kind of tools or assessments that you might use when it comes to the more school age children and what that looks like?
So we use a variety of tools that basically test object recognition, figure ground perception, motion perception, visual spatial perception, visual short-term memory.
Wow.
And we use both motor dependent and motor free tools. So we have tools, for example, the test of visual perceptual skills and the VMI-BIRI, which a lot of physiotherapists also use. And then we also have more specific tools which were developed, for example, in Leuven, the L94 object recognition task. And that's more about object recognition. And we use some subtests of different intelligence tests because they test also the visual processing. So we basically, when we test the child, we take all the results from a big, extensive testing battery, and we develop a profile for the child, as Alison was mentioning, so we can highlight the child's strengths and know which difficulties to focus on first. And then, finding the best way to manage and help the child.
It's really, carefully stepped through, isn't it? Can you give me some principles? And I know, we don't have time here. This is a big topic, but just general principles of what an intervention strategy might look like, or things that you might recommend for, say, a school-aged child versus a very young infant. Can you give me some examples of what that could be, Nofar? So some common recommendations, maybe.
Well, I think the most recent research that I worked in, which would probably be applicable, was about visual fatigue, identifying the visual fatigue signs a child may experience. So there are some children who can experience these signs.
What does that feel like or look like? How might someone describe that?
We developed a questionnaire which we used. It was actually an observational tool that we used in different settings. So, for example, when a child is doing their rehabilitation, when they're being tested in the clinic, and to be mindful of watching the child. And for example, a child might be rubbing their eyes or might be talking a lot to avoid doing a visual task. So there are different visual fatigue signs that we look at. And we found in our studies that it relates to clutter, so how the environment is for the child and how it affects the child. And so there hasn't been a lot of effectiveness to see whether reducing the clutter, what kind of outcome it has for the child, but there are some relationships, and it appears that there are strategies to accommodate for the child and to help them be in an environment which is more simple, so that they can really focus on the visual task at hand, with more contrast, with more space between words, for example, if they're reading.
So a great environmental review of what their setting might look like. Because I can imagine a lot of classrooms are very cluttered. There's things, I've been to recently gone to some primary schools or kindergarten, and sometimes you go and then you're like, oh, that was very stimulating. There's things everywhere and it's loud, and even I find it difficult to contrast what's happening. But I can imagine that environmental review would be so integral for a child to function well in their classroom.
So, and again, we would think about that individual child and what they are having difficulties with, and focus the intervention relevant to them. So, they might prefer, because they might have very good verbal skills, so they might want to, actually give the instructions verbally rather than talking through what the visual task is, or giving them another way to, because they may struggle with writing, so give them some other way. So there are a lot of different strategies. And we didn't talk about infant assessment. There's so much to say, but I think my main message about infant assessment is perhaps two tools that we use: the near detection scale, developed by Sonksen, and we've published about it, and the
which is spoken about in your last podcast interview. So I encourage everyone to go and listen to that one. Just look up Alison Salt.
And we also now use the PISA infant vision assessment battery, which is just a nicely structured assessment that you can actually score, much like the Hein, which I think helps to concentrate the mind on what you're observing. But again, it is really just careful observation, looking at the child's acuity, but also what they're detecting, what they're fixing, following, what their eye movements are like. So it's a very structured approach, and that's what we're using currently.
Okay.
And you talked about ways to support the infant.
Yeah.
And we generally think about two aspects. One is, as we said earlier, that you can help a baby to for their vision to develop faster if they have potential for the vision to develop. And potentially the most critical thing is that you want to engage the child's cognitive interest in looking.
Okay.
So we don't promote passive looking and waving things about in the environment. The baby needs to be engaged cognitively, reaching, touching, feeling.
Right.
And you use, based on your assessment, what you believe the baby can just see. And then it might be in a dark room with a lit up toy, guide their hand to the toy so that it's more meaningful to them. And then gradually increase the challenge as you do in all therapies.
Yes.
And it might be what they detect and then what they can fix and follow. So helping them to learn to move their eyes in a coordinated way. So that would be vision promotion. And then we want to support the baby learning each goal for their development and making sure that the toys that you're using to help them learn are visible. So it might be they're just aware of black and white objects, but not really anything sort of less contrasting. So you would make sure that the toys you're teaching them with are black and white, well contrasted. Think about the environment again, about the clutter. So those kind of simple, practical approaches.
That's wonderful. And I love, thank you for sharing those principles. And I understand obviously that the assessments will really guide that and provide you with that information. That partnership with families is crucial, and finding interest. And I think there's common themes with a lot of this, isn't it? When you think about the principle of neuroplasticity, they don't just apply to learning motor tasks. They actually go hand in hand. And engagement is always the most important thing. And spending time to find out what a person is interested in, a child, an infant is interested in, is well worth it, isn't it? Because that's how we're going to get the practice and repetitions, something that means something. And I love how you said, to touch the toy and feel it. That's all about the interpretation of what they're seeing, and everything goes hand in hand. And again, if we start cutting everything up of what we're doing, it doesn't make sense, does it?
No, exactly. I mean, we look at the principles of motor learning. They're exactly the same. We just have to, we know it really.
Yeah.
We just have to think vision.
That's right. Put that lens on, quite literally. I felt so funny then, but I wasn't even intentional. Thank you so much for this incredible masterclass that this was, actually. So I'm so looking forward to these guidelines being published. I know you've been working on this for quite some time because it's a huge body of work and needs consensus from an international group. So it's a big piece of work. But thank you here right now in teaching us, bringing more awareness to this area, because I think we all have greater opportunities now with, early detection, now early intervention, of making sure that we are capitalizing on those opportunities and not just thinking in our silos of, motor skills or fine motor skills. Actually, the vision is what drives a lot of that. So thank you. And thank you for giving us more hope about what it is that we can do.
Thank you.
Yeah,
thank you, Dana.
Thank you very much.
Okay.
To all of our listeners, I hope you really enjoyed that. A wonderful chat. And, when the guidelines do come out, we'll be sure to tell everyone about it as well, and make sure we spread the news about it, because I think we can all learn a lot from it. But for now, I'll say thank you and goodbye. Bye, everyone.